Thank you for inviting me to speak at this extremely well-attended conference. My title, as Dave said, was to update you on the management of IBD in the face of drug monitoring and where we've evolved from what he said exactly, which was just measuring it at the time of loss of response and then figuring out what you're going to do, to taking on a much more proactive approach to monitoring. So, there we go. So what we're going to do is I'm going to give you a little historical perspective. We're going to understand the overall pharmacokinetics of tumor necrosis factor, talk a little bit about reactive versus proactive monitoring, move beyond loss of response, and what the future is going to look like in terms of using pharmacokinetic dashboards. So historical perspective is just to plant the seed of where historically the drug levels came from and where they were originally used. It actually started, Alana Mazer in 2006 published the idea when she was with the late Gordon Greenberg in Toronto at Mount Sinai, looking at if someone's sitting in the chair at the time of their infusion and you drew a level and it was detectable. This was just whether it was detectable. This wasn't a specific cut point. And what they declared is that if you have a detectable level, you had better endoscopic response and you had better clinical response to the therapy. This was then also looked at in ulcerative colitis, interestingly, when they went back to the Act 1 trial, so the registration trial for Infliximab for ulcerative colitis. And if you look at 6 months, it's kind of depressing that only 24% of our patients were off steroids and in remission, meaning meeting the primary endpoint. The idea was that perhaps if we actually had optimized drug levels, could it be that the response was more closely looking like what we were seeing in clinical practice, where we were employing drug levels? And what they found, indeed, was that in individuals who had therapeutic drug levels, meaning were beyond the second quartile. So if you look at the top two quartiles, meaning the 50th to the 75th percentile and the 75th to the 100th percentile, you could see that the remission rate, meaning the primary outcome, was closer to 50 to 60%. So the theory is that individuals who were doing better on Infliximab was tied to the fact that if you had better levels, you would do better. Same concept that goes back to thiopurines. The idea that if you have a good 6-TGN level, you had a 5-fold increase odds ratio of being in response or remission. The same concept applies to using any of our therapies, that there is a therapeutic level that we can try and achieve. And Ray spoke beautifully about updating us on some of the levels that have been shown to tie to not just clinical efficacy, but more importantly, mucosal healing. And it looks like there's a ceiling that you've disclosed, Ray, in terms of that beyond a certain level, you didn't get that much more. However, we know that for perianal disease, potentially you may need more. And at DDW this year, there was an abstract that showed that even achieving levels closer to 20 was enabling individuals to actually achieve healing of their fistulas. So what drives someone to metabolize these therapies differently? What is it about the pharmacokinetics that helps us understand why drug levels are important? We don't know in the future whether or not small molecules, for example, whether the future of tofacitinib or mongersen or Receptos oral small molecule, whether there's going to be any tie to a drug level or a certain way that someone clears it. So for the moment, we've got the anti-TNFs, we've got Entyvio, for which we don't have an assay yet, and then also with ustekinumab that will be coming out in the fall, we hope, you will similarly need to understand PK and the drug levels, because we know already at DDW there was an abstract that suggested that the week 8 level of ustekinumab predicted durability of the therapy. So we already know that early drug levels are going to actually relate to how these people stay on drug. And the drug level they declared for ustekinumab was greater than 4.5. We will assess what that means. So it seems like around 5, which is going to be easy for us to all remember, seems to be a therapeutic level for something we can try and achieve. So what impacts pharmacokinetics? We all know and we've heard about the presence of anti-drug antibodies antibody, which clears the drug and therefore lowers the amount of active drug that's available. These are neutralizing, not just binding antibodies, but neutralizing antibodies, which actually take the drug out of play and make it such that an individual will not have enough therapeutic drug level. Concomitant use of immunomodulators increases drug levels. So the idea, Ray, was actually, I was intrigued, Ray, because you had, in theory, good drug levels, but you were adding methotrexate maybe for mechanistic, less so for increasing drug levels. You'll have to tell me during the panel whether that was your thought process as opposed to switching at a class. But the idea that the immunomodulators, there's a lot of debate whether or not, for example, in SONIC, which again was shown as to be the gold standard, best achieved outcome when you combine thiopurine with anti-TNF therapy, that those individuals, were they improved because there was two different therapies that we've used for IBD, or was it because the thiopurine was augmenting the drug levels of the anti-TNF, therefore improving its efficacy? I think that'll be a debate forever until we get rid of combo for good or move on beyond TNF, whatever the future holds for us, but that will be an ongoing debate at every meeting. We know that individuals who have low albumin, Dave showed some of the clearance issues that he noted, that high CRP, low albumin, high BMI, those clearance issues will affect all of these biologic therapies we're dealing with, and therefore individuals will clear the drug quicker. Gender, males have had higher clearance. So the idea of antibodies, let's start with that. There's a lot of debate on whether or not there's such a thing as transient versus are they sustained antibodies. The idea of transient antibodies was actually introduced by Niles van de Castile in 2013 in an AJG article, where he looked at patients who every infusion they got antibodies in levels. And they had something like 1,500 levels or something to evaluate, and what they saw is that over time, about 28% of patients actually lose that antibody, meaning it's transient. However, we didn't account for the fact that maybe they changed the dosing or escalated or changed the frequency, and maybe that's why they went away and weren't detected, meaning they actually manipulated the drug, how the drug was administered to actually get rid of the antibodies. It's unclear. But one thing we learned is that if an antibody level was above 10 or happened within the first 6 months of exposure to the anti-TNF therapy, those were unlikely to be transient. So the idea that higher antibodies and happened quite early, those were thought to be much more sustained. Those were going to be more sustained over time. And we know that when antibodies happen, if you can't so-called overcome them, these patients have loss of response over time, and therefore the survival of being on Infliximab in this study, as you can see, was significantly less in the face of sustained antibodies, which is the solid line. So what about the impact of rapid clearance, especially with these therapies? Dave noted BMI, albumin, and CRP. This was also an interesting abstract presented by Gord Greenberg, where he wanted to highlight that if the actual half-life of anti-TNF therapy sits somewhere between 12 and 14 days, he wanted to highlight that in this individual, the half-life in a hospitalized ulcerative colitis patient was tenfold faster, meaning 1.4 days. So if you say you clear after 5 half-lives, that means by day 5, no drug in the system. So the idea here was to say is that when you clear the drug really quickly in the face of markers of high clearance, such as a lot of inflammation, where these individuals are just losing the drug through their stool, basically into their stool through the colon, it's really hard to catch up. So a lot of debate on whether or not we should be using higher doses in hospitalized acute severe ulcerative colitis patients. For example, my standard practice is 10 milligram per kilogram in a hospitalized UC patient. I've just evolved to that with the idea that hoping to minimize the clearance, increase the tissue concentration. But the point is, which has been shown in multiple studies, that the faster you clear, the lower the drug level, and then all of a sudden the antibody levels start to rise. And already in acute severe ulcerative colitis, 20% of patients already have antibodies by week 6. So the idea is that how do you augment this clearance process, and how are you one step ahead of the fact that these sick patients, which is vedolizumab would be the same, and I'm guessing ustekinumab would be the same as well, all of these factors impact clearance. And what we know from the Branzi paper that was published in Gastro is that when they looked at the fecal levels of TNF compared to the serum levels of TNF in a sick hospitalized colitis patient, there was more TNF in the actual stool measurable even on day 1 than there was in the serum. So the idea, unfortunately, that when we give a drug to actually manage the colitis, unfortunately, that is where the drug is preferentially disposed of, which is in sites of inflammation. So you can see, and you can imagine that a large surface area such as the colon, as opposed to a joint, for example, we've got a lot more loss in patients with inflammatory bowel disease. Therefore, we struggle a lot more with low drug levels and antibodies, and stresses the importance of PK monitoring, which differentiates us from the IBD care compared to rheumatologic and dermatologic care, because drug levels is just not on the table. It's not just part of their usual plan of care. And Sonic really started the conversation that maybe if you actually partnered a TNF with a immunomodulator, you would actually be able to decrease the antibody formation, where there was 1% versus 14% in the monotherapy Infliximab arm and Sonic, which started, as I said, the dialogue that, well, why does combo work better? Is it because you are actually minimizing anti-drug antibodies and therefore letting more of the actual TNF be available to actually do its thing? And also there was higher drug levels in people who were on combination therapy compared to patients who were on monotherapy at the time of Trough. Now, there's been smattering of publications where people have taken individuals who are on monotherapy, added an immunomodulator when patients had antibodies, and have seen that the antibodies actually go away and the drug levels start to rise. I'm sure we all have a handful of those kinds of patients where you've done something where we call overcome antibodies, but again, in the face of really high antibodies, you're probably better to just move along to another anti-TNF or within class if they actually were a responder and then lost response due to quite a significant amount of anti-drug antibodies. Now, a lot of people will also comment on the fact that maybe if we're kind of concerned about combination therapy, because we know you get more infections in pediatrics, there's a higher risk of malignancy, almost a 3-fold increased risk of malignancy in terms of combination with a thiopurine for pediatric patients. The idea is maybe can we use less of the thiopurine, meaning in Sonic you use 2.5 milligram per kilogram of azathioprine, which is the standard dose for which we know the data and the literature in terms of efficacy. Here, Andreas actually presented with Maria Abreu the idea that maybe you don't need a 2.5 milligram per kilogram, forget the dose of the immunomodulator, focus on the drug level, meaning go back to measuring your 6-thioguanine levels and saying that if you had a drug level of at least 125, you don't have to worry about this 235 nonsense, just try and get a level of 125 or above, was predictive of actually diminishing antibodies and increasing drug levels. And in the end, at DDW this year, there were 2 abstracts that similarly confirmed that finding. One of them actually said you need one of 105 or above, and another one was just saying you don't need high dose, you can use low dose, which was considered 1 milligram per kilogram of Imuran. So the idea is that maybe we'd be able to minimize the risk tied to combination therapy by not necessarily pushing the thiopurine. Possible and still on the table, because I don't think people are ready to abandon that completely. The COMMIT trial, which was using methotrexate as compared to Sonic, similarly looked at combination. The efficacy outcome was no different compared to Sonic, meaning the COMMIT trial did not show a positive difference between combo and mono, unlike the Sonic. However, the trial design was completely different, the type of patient that went in, so I'd almost ask you to ignore the efficacy component of COMMIT and focus on the antibody and the drug level component of COMMIT, which showed exactly the same as Sonic, that when someone is on a concomitant immunomodulator, they had less antibodies and higher drug levels, and those individuals did better. So it's the same concept, and I don't think we need to debate that any further, that definitely you get better drug levels and less antibodies when you use combination therapy. Whatever one you choose to use remains the best option as compared to monotherapy, but at the end I'm going to show you, and now as we move into the future, that maybe we can think about non-combination therapy if we actually use drug levels very early. So let's move into this idea of optimized monotherapy and when to check drug levels and going beyond reactive. And here was, interestingly, even a more recent publication within a year of, again, telling people how to use drug levels, and everyone just talks about it in a very reactive way. When your patient is not doing well, please check a drug level. If they're antibody positive, do something. If they're antibody negative and they're low drug levels, increase the dose. I mean, again, that implies we are waiting for people to declare themselves non-responders. That is not where we can be if we want to be one step ahead of these biologic therapies. It's very important to note that we need to, again, move beyond just thinking about loss of response or just a random check to see how someone's doing, because those are the individuals that will eventually lose response and the durability of the therapy will be minimized. So again, the idea is that we continue, and Gil and I, Gil was the first author actually, we're at a RAN panel ran by Gil and Corey, part of the Bridge group, where we were asked to actually interpret the appropriateness of drug monitoring in certain scenarios, certain case scenarios. And one of the things that was just why I bring it up is that there is literature out there for you to use to look at what a panel voted on when it is appropriate to, for example, switch, when it is appropriate to dose adjust. And I bring out secondary loss of response because that was the title for the talk, but in the appropriateness paper, there was also talking about primary non-responders and what are optimal drug levels. When you restart a drug, what should be appropriate? So I do want to lead you to that paper and advise you to please look at it. And there's also an app through the Bridge website that you can actually go onto, or a program where it will help you determine what your next move would be. What is the website? Just bridge.com? bridgeibd.com, and if you go there, it actually lets you put in the different scenarios, and it'll actually tell you what is appropriate and what would be inappropriate to actually do and help you with your next move. So that's why I wanted to highlight, and I didn't, sorry to keep it busy, it was just to bring out the idea that, again, there are tools out there that can help interpret this moving target of drug monitoring. So the whole idea of proactively assessing what happens next was done retrospectively. So we'll first start with the first paper, which was the Accent 1 paper that was published in Gut of 2014, where what they did is they went back to the original, I mean, this is 1990s into early 2000, they went back to the actual, to the caves, to the archives, and actually showed us that at week 14, so someone already, when they're sitting in the chair for their first maintenance infusion, that a level of at least 3.5 or greater was shown to be associated with more durability, meaning at their primary endpoint of week 54, more people were still on drug. So it was the concept that if you start maintenance in the right way, you're probably going to stay in maintenance in the right way unless you get some big flare or some other reason to alter the pharmacokinetics. So if you made it to week 14, and what we considered to be, we're moving our target up a little bit higher in terms of our target of interest, but if you met 3.5 or greater, you ended up at better outcome and more durable. Likely because you didn't develop antibodies, and I used the term yesterday that I'm going to use again because Dave likes the term, is that the idea that you didn't trough out, meaning you didn't fall out of trough. You continued throughout your maintenance to actually have a trough that was actually detectable and somewhat in a state where people wouldn't get antibodies. We similarly published in 2014 in pediatrics, almost at the same time that they published Accent, that we looked at week 14 and we actually found that if you had a drug level closer to 5, you actually had more durability and you were on drug at week 54, doing well, exactly the same, almost like what would have happened in a registration trial. That was looking at how many people were on Q8 week 5 per kilo. You know, again, suggesting that if you had a certain level or PK going into week 14, it predicted what you were doing in the future. We also looked at what drug level at week 14 gave you the best outcome of being more durable at week 54. And interestingly, the positive predictive value of being in remission, doing well at week 54 on the drug dosing you should have been started on if you had a level of at least 7 at week 14. So remember, a drug level post-induction may be very different than a drug level in maintenance and being stable. So don't confuse the fact that just achieving a drug level 3.5 or 4, your patient may need more as they head into maintenance. There's a recent publication from CHOP that also looked at saying that week 10 levels may be even more predictive of week 54. So we keep getting earlier and earlier in ratio. The lovely UC trial looking already at week 6, predicting durability and short-term mucosal healing. And this study showed that if you had a drug level of at least 9 at week 10, you actually achieved better outcome out to week 54. And this was the study that Ray just showed, that short-term mucosal healing, that individuals who had higher drug levels at week 2, week 6, did better in terms of looking at the endoscopy in terms of mucosal healing. So it looks like we are not waiting anymore for maintenance and for a patient to fail. You have the data now to tell you what your drug level should be early to actually predict durability. And the best thing we have, which is what Ray showed, which is this publication showing that we actually tie it to mucosal healing. You can't get more objective than actually showing that there's a minimal drug level that you need in order to achieve the outcome of interest, which we're pushing ourselves to, which is mucosal healing. And this was just, again, reiterating that what drug level was associated, even in the multivariate analysis, what continued to be the odds ratio of having mucosal healing if you had a drug level at week 6 greater than 15 was close to 5. So I'm asking you that in UC that you even move closer within the induction period to actually think about what your next dose frequency should be, meaning should the patient wait 8 weeks? If the patient's drug level is 10 or 5 at week 6, you need to bring the patient in. You're not going to wait for the patient to have a drug level of 0 and wait 8 weeks. So it's really about starting to use drug levels to help you decide what you're going to be doing next. In terms of adalimumab, also showing that individuals who had a drug level of adalimumab of at least 5 compared to less than 5 at week 4. So this is 0, 2, 4. Individual is getting their third adalimumab injection, and those patients had much better durability if their week 4 level was 5 or above. So you can now start doing this early and not waiting for these reactive approaches to drug monitoring. And just to show you that in individuals who had drug levels less than 5, they had 20% of higher rate of anti-drug antibodies. Interestingly, in patients who were on concomitant immunomodulators, they actually had less adalimumab antibodies. I say ADA, but it's anti-drug antibody, I'll say it in this sense, quite significantly. I mean, the ratio was 0.323, so there was a huge protective effect of using concomitant, and not shockingly that the odds of discontinuing drug in the face of antibodies early was threefold loss of response in individuals with antibodies. The TAXIT trial is probably one of the most well-cited trials, which was a dose optimization trial where they actually took people who had a low drug level, less than 3, escalated their dose to put them in a range of 3 to 7, took people who had a drug level greater than 7, put them into a range of 3 to 7, and basically followed them over time, and they were randomized to either getting very frequent drug monitoring or getting a drug level when they were losing response. The point of TAXIT was not the randomization piece. The point of TAXIT was that individuals who said they were feeling well or were considered responders, and you optimized their drug level, their Harvey-Bradshaw improved and their CRP improved in Crohn's disease. So the idea is that even though patients feel well subjectively, as Ray noted, that there's a good chance that these individuals actually had not as well mucosal healing, and therefore by optimizing them it's important. Adam Chaffetz and Byron Vaughn also showed us and published an IBD journal 2 years ago of being able to actually nimbly use your drug monitoring and keep a patient on a drug level between 5 and 10. And what he showed us is that if he compared his practice, which is proactively optimizing drug levels versus his partner's practice, who may get random drug levels or no drug level, look at the durability of the drug in individuals who were actually optimized in real time, and particularly those who had a drug level between 5 and a trough greater than 5. So we know now what the future is going to look like. We understand, and I hope everyone walks out of here. The objective was to say, please, I'm begging you to get proactively involved in your monitoring of your patients with anti-TNF therapies. It will make a huge difference to their lives, and it will keep them on the drug. But what the future is going to look like is called dashboards. Dashboards are going to be computer programs where you go into your computer, you put the patient's BMI, you put the patient's albumin, you put the patient's CRP, you put in a drug level, and it's actually going to tell you the dose and frequency for which you need to give these drugs. This was interesting. This was a fast-clearing patient. She had very low albumin, high CRP, so I wanted to see what dose I would need to use to achieve a trough level of 5 in this rapidly clearing patient. And it told me that I can give 23 milligrams per kilogram every 4 weeks in order to give this patient a trough that would be considered to be acceptable for efficacy. Obviously not possible. So right now what this is showing us is that there are certain individuals where this drug may not be the right drug for them. So the ability to think clearly about how to manage these patients in the face of the individual pharmacokinetic is really critical. And the dashboard's really cool because it will actually show you when the patient will trough at the various levels. This pink line is for a trough of 7, for example, and it tells me that if the patient was scheduled for a dose on August 1st, I'd have to bring them in 2 weeks earlier if I didn't want them to fall below a trough of 7. So imagine being able to actually see when your drug dose should actually be happening, and you can actually toggle what trough you want, and you'll be able to see what the individual patient's drug frequency and dosing should be. So that's what the future will be. So in conclusion, measurable drug levels are associated with improved response outcomes. Anti-drug antibodies are associated with decreased efficacy. Drug levels and antibodies can help guide treatment decisions. Optimized monotherapy may be the fact that if we can actually optimize the drug early, like at week 6, and bring them in, instead of waiting 8 weeks, bring them in 4 weeks, you may actually be able to abort antibodies by actually optimizing your drug level. So that may be the future, that optimized monotherapy may enable us to not have to use combination therapy and minimize the risk. And dashboard-guided dosing is closer than we think, and we're actually studying that in patients right now and looking at ATI-free survival at a year compared to patients who are not dashboard-guided. So thank you so much.